Hello, and welcome to Medical Voices, the podcast where we learn the language of healthcare, one real conversation at a time. I'm Nadia.
And I'm Tom. Really glad you're here.
Before we start, a quick but important note. Everything you hear on Medical Voices is here to help you learn the language of medicine. We're not here to give medical advice, and nothing in this episode should be taken as clinical guidance.
We're language teachers, not your doctors, though between us, we do spend a lot of time in clinics.
We really do. So, episode 1. And we're starting at the very beginning of any clinical encounter.
The first GP appointment. Your general practitioner, your family doctor. The first port of call for almost any health concern.
It's one of the most universal clinical situations there is. Whether you're a nursing student, a healthcare professional working in an English-speaking country, or someone preparing for an OET exam, you will encounter this many times.
And there's a specific vocabulary that goes with it, which is exactly what we're going to look at today.
In this episode, 10 essential vocabulary terms, a full GP consultation roleplay. I'll be the doctor, Tom will be the patient, a language breakdown, and a short quiz.
I'm Mr. Davies today. First time at this particular clinic. A little nervous, honestly.
We'll also repeat 3 key exchanges from the roleplay at a slightly slower pace, so you can really focus on the phrasing. Let's get started. Right, before we get into the roleplay, let's make sure we have the right words. 10 terms. I'll give you the word, the definition, and an example sentence. Pause and repeat whenever you need to.
Take your time with these. Getting the vocabulary right really matters in a clinical setting.
Term 1. Chief complaint. The chief complaint is the main reason a patient has come to see the doctor, their primary concern. Example. The doctor asked Mr. Davies to describe his chief complaint in his own words.
Term 2. Medical history. A patient's medical history is a record of everything clinically relevant from their past illnesses, surgeries, chronic conditions. Example. The doctor reviewed his medical history before making any decisions.
Term 3. Vitals. Short for vital signs. The core measurements that give a clinician a quick snapshot of a patient's physical state. Blood pressure, heart rate, temperature, respiratory rate. Example. The doctor recorded Mr. Davies' vitals at the start of the appointment.
Term 4. Blood pressure. The force of blood pushing against the walls of the arteries measured in millimeters of mercury, mmHg, it's expressed as 2 numbers. A typical normal reading is 120/80. Example, his blood pressure was 122/78, within the normal range.
Term 5. Allergy. An adverse, that means unwanted or harmful, reaction of the body to a specific substance. Medications, foods, latex, all common allergens. Example. Mr. Davies reported an allergy to penicillin.
Term 6. Symptoms. The signs and sensations a patient experiences and reports. Pain, fatigue, dizziness, nausea. Example. He described his symptoms as a dull headache that had been building for 2 weeks.
Term 7. Prescription. A written or electronic authorization from a licensed clinician, a doctor or nurse practitioner, allowing a patient to obtain a specific medication from a pharmacist. Example. The doctor issued a prescription and explained how to take the medication.
Term 8. Follow-up. A scheduled appointment after an initial consultation to check how a patient is progressing. Example. The doctor asked Mr. Davies to book a follow-up in 2 weeks.
Term 9. Over-the-counter. Medications you can buy directly at a pharmacy without a prescription. Paracetamol and ibuprofen are the standard examples. Example: he had been managing the headaches with over-the-counter ibuprofen.
And term 10, referral. When a GP decides a patient needs specialist care, they refer that patient to the appropriate specialist. Example: the doctor considered a referral to a neurologist if the headaches didn't improve.
10 terms. You'll hear all of them in the dialogue coming up. Pause and go back now if anything felt unfamiliar.
Ready when you are.
All right, and now, as always, it's time for our role play. Today I'll be Dr. Bennett, the GP.
And I'll be the patient. Mr. Davies, let's go.
Good morning, Mr. Davies. I'm Dr. Bennett. Please come in and take a seat.
Good morning, doctor, thank you.
So, what's brought you in today? What's your chief complaint?
I've been having headaches pretty much every day for the past 2 weeks. They start at the back of my head and spread forward.
I see. And on a scale of 1 to 10, how would you rate the pain at its worst?
Maybe a 6, sometimes 7. It's not unbearable, but it's really affecting my concentration at work.
Understood. And have you noticed anything that makes the symptoms better or worse?
They're worse in the afternoon. Better after I sleep, usually.
Good to know. Let me take a look at your medical history. Any significant illnesses, surgeries, or chronic conditions I should know about?
Not really. I had my appendix out about 8 years ago. Nothing else as far as I know.
And are you taking any medications at the moment?
Just ibuprofen, over the counter. I've been managing it myself, but it's honestly not cutting it anymore.
All right. Any known allergies, medications, foods, anything at all?
Penicillin. I had a reaction as a child, a rash. It was noted in my records at the time.
Noted. Allergy to penicillin. I'll flag that clearly. Now let me check your vitals. I'll start with your blood pressure. Your blood pressure is 122/78. That's very much within the normal range. Temperature and heart rate are both normal as well. Your vitals look good, Mr. Davies.
That's a relief. Is it anything serious, doctor?
Based on everything you've described and the examination, I think what you're experiencing is most likely tension-type headaches. They're extremely common, and in your case, almost certainly being driven by stress and insufficient sleep, both of which you've mentioned.
So what do I do?
For now, I'm not going to write a prescription. I'd rather we start with some straightforward lifestyle measures. Improving your sleep, reducing screen time in the evenings, managing the stress where you can. The ibuprofen you've been taking is appropriate for this type of headache. Try taking it earlier rather than waiting for the pain to peak.
And if it gets worse before my follow-up?
If the pain becomes severe or you develop a fever, visual disturbances or nausea, come back straight away. But I don't expect that. I'd like to see you for a follow-up in 2 weeks. My receptionist will sort out the appointment for you on the way out.
And if the headaches don't improve with all of that?
Then we'll reassess. Depending on what I find, I may consider a referral to a neurologist for further investigation. But let's give the lifestyle approach 2 weeks first.
That sounds very reasonable. Thank you, Dr. Bennett.
Of course. Take care, Mr. Davies, and do try to get some more sleep. We're going to repeat 3 key exchanges from that dialogue, just a little more slowly, so you can focus on the phrasing and the vocabulary.
Listen out for the clinical terms. See how naturally they come up.
So, what's brought you in today? What's your chief complaint?
I've been having headaches pretty much every day for the past 2 weeks.
And have you noticed anything that makes the symptoms better or worse?
They're worse in the afternoon. Better after I sleep, usually.
Let me take a look at your medical history. Any significant illnesses, surgeries, or chronic conditions?
Not really. I had my appendix out about 8 years ago. Nothing else.
Any known allergies, medications, foods, anything at all.
Penicillin. I had a reaction as a child.
Noted. Allergy to penicillin. I'll flag that clearly. For now, I'm not going to write a prescription. I'd rather we start with some lifestyle measures.
And if it gets worse?
I'd like to see you for a follow-up in 2 weeks. If things don't improve, we can look at a referral to a neurologist.
That sounds very reasonable. Thank you, Dr. Bennett. Great. Let's break that down, Nadia. There were a few expressions in there worth looking at more closely.
Yes, 6 things. Some vocabulary terms, some phrases, and one big picture language point at the end.
I said, I've been having headaches. That's patient language, informal, personal. Nadia immediately reframed it. What's your chief complaint? That's the clinical term, and it's how the complaint gets documented.
This shift happens in every clinical encounter. The patient describes something in everyday language. The clinician translates it into precise terminology for the record. Chief complaint. Tension-type headache. 2 weeks duration.
For OET candidates, you'll often need to elicit the chief complaint at the start of a role play or document it in a written referral. Using this term fluently signals professional register from the first line.
One of the most universal phrases in clinical English. On a scale of 1 to 10, how would you rate the pain? It's a fast, standardized way to quantify a patient's experience and track changes over time.
The patient doesn't just say a number, they add a qualifier, a 6, sometimes 7 at its worst. That qualifier is clinically useful. A pain that fluctuates tells a different story from one that's constant at a steady level.
You'll need to both elicit this and document it. Patient rates pain 6 to 7 out of 10 at peak intensity. That's how it looks in a clinical note.
Notice what Nadia did. She gathered the pattern, worse in the afternoon, better after sleep, but she didn't name the condition until she'd completed a full assessment.
Your job when taking a history is to gather and document what the patient reports. The diagnosis comes later, based on the full picture. Saying tension headache after the first question would be premature and potentially wrong.
This distinction matters enormously in OET role plays and written tasks. Describing what the patient reports is different from stating a diagnosis. The clinical language you choose reflects that difference.
These 2 terms define the 2 main access routes for medication. A prescription requires authorization from a licensed clinician. The pharmacist cannot dispense without it.
An over-the-counter medication you can buy directly at a pharmacy, no authorization needed. In the role play, I'd been taking ibuprofen over the counter, which told the doctor I'd been self-managing without a formal diagnosis.
That piece of information, it's not cutting it anymore, was a clinical signal. Self-medication that's failing is a prompt to investigate further. Nothing in a clinical conversation is just small talk.
Follow-up carries real clinical weight. It means we're not done. We're tracking your progress over time. Book a follow-up in 2 weeks is a standard close for any consultation where the outcome isn't yet clear.
It works as both a noun and a verb. Book a follow-up, noun. We'll follow up in 2 weeks, verb. Both are correct, both are common, and you need both for clinical writing and speaking.
In OET written tasks, referral letters, discharge summaries, recommending a follow-up is often a required element. Using the term precisely strengthens your professional register score.
Step back and look at the full picture. Throughout the role play, Tom and I were operating in 2 very different registers, and that was deliberate.
Patient language. I've been having headaches. It's not cutting it anymore. That's a relief. Conversational, personal, imprecise. Exactly how patients actually talk.
Clinical language. Chief complaint. Allergy to penicillin, noted. Vitals within normal range. I'd like to see you for a follow-up. Precise, structured, documented.
Moving fluently between these two registers is one of the core skills in medical English. Talking with a patient requires warmth and clarity. Documenting and reporting requires precision and professional terminology. Both matter. Both take practice.
That's what we're building here, episode by episode.
6 points, patterns you'll see again and again across the episodes.
And now, the part that locks it all in. It is quiz time. 3 questions. Tom, you ready?
Always.
Question 1. What is the clinical term for the main reason a patient comes to see a doctor? 5 seconds. Think before you listen.
The answer is chief complaint. It's the primary, or chief, concern the patient presents with. It's the starting point of every clinical encounter, and clinicians ask for it in various ways. What's brought you in today? Or, what's your main concern? But in the clinical record, it's always the chief complaint.
Question 2. What does vitals refer to? Name at least 2 examples from today's roleplay. 5 seconds.
Vitals, short for vital signs, are the core measurements of a patient's physical state. Today we heard blood pressure, temperature and heart rate. All 3 are standard in a GP appointment. Respiratory rate is also a vital sign, though it came up less explicitly.
Question 3. What is the difference between a prescription medication and an over-the-counter medication? 5 seconds.
A prescription medication requires written or electronic authorization from a licensed clinician before a pharmacist can dispense it. An over-the-counter medication you can buy directly at a pharmacy without any authorization. In the roleplay, ibuprofen was the over-the-counter example, and a potential prescription was what Mr. Davis was hoping for but didn't receive today.
3 questions, 3 strong answers. Well done if you got those. And if you didn't, the vocabulary section of your PDF transcript has everything you need.
That's it for episode 1. Mr. Davis has his GP visit behind him, and 1 question remaining. Where does he go to actually get his medication? We're heading to the pharmacy. Prescription, dosage instructions, side effects. A whole new clinical setting. Nadia?
Episode 2 is everything that happens when you walk through that pharmacy door. Don't miss it.
See you next week.
See you next week.